The other patient that I got to sit in on with our PT down in the Bethesda office was a patient coming in for lateral epicondylitis. Now, they've already been to their orthopedic, and it's an orthopedic that we have a great relationship with in that community, in that area. We have a lot of mutual patients that we tend to see eye to eye on in regards to our treatment philosophy, the sequence of events of how we progress them through activities, and just the types of PT that we like to do with individuals, especially with these tendinopathy related issues. With this individual, he actually developed the irritation after attempting to do a push-up challenge with his son about a year ago. So this has been chronic in nature. He has been to the orthopedic. They have tried injections, and they have tried just some over-the-counter anti-inflammatories as well. But admittedly, from the patient, from a PT and rehab side of things, he's kind of a blank slate. He has not attempted anything at this point. So with this individual, it's kind of a fun one to start with because they have not attempted anything from an activity modification, from a symptom reduction or self-care standpoint, from a manual or a hands-on lens. They haven't done anything from a mobility, from a strength, or just from a general reconditioning standpoint. So we have a lot of areas to intervene, a lot of entry points to work on with this individual. And it's also nice because we can segregate what we do with them into things that can be done at home versus things that we can prioritize in clinic. And that's something that I struggled with early on with treating tendinopathies, whether it was medial or lateral epicondylitis, whether it was an Achilles tendinopathy, but trying to find that balance of how much do they need supervision on versus how much can we just teach them to do at home and then focus on other bigger picture things in the clinic. So with these, I always like to look at these types of individuals where we want to make sure we are giving them kind of what the PT School 101 expectation is when somebody comes in with this condition, which a lot of times that tends to be stuff that you can teach them to do and they can do on their own at home. So we went through different self-care strategies for him in regards to delineating the type of pain that he's having and really teasing out how much of this is true extensor mass irritation of where the tendon meets the lateral epicondyle, versus teasing out how much of this may be some neural tension that's developed or just some neural irritation of where the radial nerve goes through that area. How much of this irritation is grip related versus extension or pronation or supination being the more provocative measure. Those findings during the eval helped us relay to him what things he can do from a strength training standpoint and from an activity standpoint to maintain just his overall daily routine. He's a runner, he likes to play golf, he does like to strength train. He just doesn't really have the guidance or the wherewithal to know what's appropriate or inappropriate to do at this time. So I thought our PT did a very good job of laying out some guardrails for him at home in regards to, hey, if you want to be active in the gym, these are the things that you can go through and you can train all day long and not have to worry about irritating the elbow. Versus these are the things that I want you to do, but we need to either modify the resistance, the range of motion, or the overall volume that we're going to do with this. So one thing that the PT did was just some light manual work with the individual, really from an educational standpoint, to kind of educate him on what lateral epicondylitis is, what tissues are involved that can exacerbate that issue if they become strained or overworked, but then also palpating some of the surrounding tissue that attaches very, very close to that area. So whether it's biceps, whether it's triceps, whether it's brachioradialis, getting into supinator, pronator teres, and allowing the individual to get an idea of what these different areas of the forearm are, what movements and what actions are going to elicit a response from that area, and then give him a better idea of what's actually the most significant area of his forearm related to his individual condition. And for him, it tended to be true just wrist extension. So from a home program standpoint, showed him activity modification, strength training routine that's appropriate to keep him active, but also keep him within a safe training parameters. Some self-massage that he can do for just symptom reduction or desensitization to that area. Showed him some light mobility for wrist and forearm tasks to maximize the amount of mobility that he has, but also tease into those minimally to moderately provocative ranges And then also got him started on some different isometric variations for the wrist and for the forearm and elbow area. One thing that I think is often underlooked for tendinopathy in this phase is utilization of BFR. And these tend to be people that struggle with progression of strength training activities because it flares up the elbow. And I think BFR is kind of a cheat code for that because it allows us to have them get the benefits of strength training, but at a reduced mechanical load because we don't need as much resistance to elicit that strength training response. So something that I have found myself utilizing more frequently with tendinopathy in the early stages is a 2 to 4 week BFR protocol where we can get anywhere from 4 to 8 training sessions in with them during a period of time where they may have an elevated symptom profile, maybe a little bit more irritable to strength training progressions. And we can build a strength training foundation and base with the BFR, and then as they get less irritable, transition to a more traditional strength training routine and begin to reintroduce some of those leisure, work, and ADL related tasks that were previously provocative.